So the basic ground rules is all of the people who are talking are stalwarts, and so it's not going to be this versus this. The whole idea of a debate is to really go into the depths of the advantages and disadvantages of each procedure. We have to understand that every procedure has its own merits and every procedure has its own demerits, and we need to take it in a humoristic but at the same time responsible manner. Because of time constraints, I've been asked to tell the speakers that each talk cannot be more than 3 minutes. It's very depressing for me to ask the stalwarts in the field to restrict themselves to 3 minutes, but that's how things go. So we without much ado, we'll go on to the first talk on Fuchs dystrophy. Again, we have two eminently qualified people to talk about this. So what is your choice? DSEC triple will be Dr. Tityal's choice, while DMEC triple will be Dr. Foglaw's choice, and I would now request Dr. Tityal to start off with his debate.
Thank you, chairpersons. 3 minutes, yeah? 3 minutes, please. It's put 1.57, to begin with.
1 minute 57 seconds.
In fact, I will take only 1 minute to, to showcase my, point. Thank you. I think looking into a triple procedure, we have graduated to endothelial keratoplasty in Fuchs. These are certain points I like to define my way of doing DSEC triple in these cases. Patient selection-wise, looking into various stages of Fuchs dystrophy, in India, we see sometimes patients very, very late, where things can be very thick corneas, hazy corneas, where DMEC sometimes may not be good choice. The DSEC would overscore in those situations as such. Donor preparation is a major challenge for us. We all are doing endothelial keratoplasty. We know that DSEC preparation, donor preparation, much, much safer, easier for us. Looking into a microkeratome assisted preparation of donor tissue gives a very, very nice ultra-thin DSEC lenticule, which is as good as DMEC preparation. That for donor age, you require less than 50 years age of patient in DMEC, where you have a compromised age and endothelial cells, while no limit for DSEC surgery. You can have even a 1-year-old child also with a huge endothelial cells. Tissue loss, which is a major concern. See here various studies. Tosif et al., 16% tissue loss, and Price et al., 8% tissue loss. That's a huge number of tissue loss happening in a country like ours, where you have a scarcity of good endothelial tissue for us. And if you imagine 2.1% ultra-thin DSEC, which is a little on the higher side from Francis Price, otherwise in our hand is 0%. Next is the endothelial cell loss preparation of donor tissue, which we know that DSEC will have very, very controlled less tissue cell loss, which ranges around 1 to 2%, in ultra-thin less than 5%, while DMEC can range from 4% to 83%, sometimes total loss of tissue also. So this is the two major concerns for me to look into a patient coming for endothelial keratoplasty. Learning curve for us, like we have graduated to a DSEC in a manner we could do it very fast and easy without causing damage. DMEC is still evolving. Many patients find a lot of challenges there. There is a higher chance of graft dislocation and rebubbling in DMEC cases, which ranges from 4% to almost 15% in those cases. Visual outcomes, yes, DMEC will give slightly rapid recovery, but ultra-thin DSEC overscores all the challenges of conventional DSEC. I have series where we have very good results in these cases. Anatomically, the major challenge is the primary donor failure, which is much more in a DMEC cases than DSEC. DSEC is well-controlled surgery for us. This is one area, graft rejection, which is less in the DMEC, more in a DSEC patient, but conventional DSEC and DMEC ultra-thin DSEC is different issue here. So I would say suitable technique for all type of endothelial keratoplasty, holds true for Fuchs also, easy, safe, and the dislocation primary failure is less with the DSEC. Therefore, I would go for a DSEC surgery because DMEC is not for all cases, not for all surgeons. and DSEC is universally acceptable to all surgeons who are doing primary endothelial keratoplasty with cataract. I think with Fuchs, I'll go for a DSEC triple in my cases. Thank you for your kind listening.
Thank you very much, Dr. Titial. We request you to please be on stage because it's going to be a very short presentation by Rajesh, and after that we can ask for questions to defend yourself. So, Dr. Titial made a very clear mention that DMEC may be a better surgical option, but not ideal for all cases, and DSEC may be comparatively an easier surgery than DMEC. So we'll now ask Dr. Fogla to refute it, and we will be asking sort of uncomfortable questions at the end of the presentations, and I would also ask you to reply with a very frank answer and not just for the debate part, so that the knowledge part of the whole thing gets permeated rather than the dualistic part. So Dr. Fogla.
Can I have my slides, please? Yeah. Now, Fuchs dystrophy, if you see a patient with corneal dystrophy and cataract, often you look at endothelial keratoplasty. The beauty of DMEC surgery is that it's minimally invasive. You can stain your Decimus donor, and in a no-touch technique, you can open up the DM scroll, and this can be very, the learning curve is pretty short, and if you find more and more surgeons are adopting this, and at the end of once your DM scroll is opened up and it's the right orientation, just put an air bubble and the surgery is done. And that's what your patient looks like post-operatively, where you cannot even make out that an endothelial keratoplasty has been done. It just looks like a cataract surgery. Anatomically, the posterior corneal curvature is much more steeper following DSEC, which leads to a hyperopic shift, which is not seen with DMEC. And this image, the ASOCT tells you which eye has had a DMEC and why the corneal anatomy is better maintained. Comparing fellow eyes, one eye having DSEC and the other eye having DMEC, this study again from Frank Price and another study from Coimbatore, from Sankara Eye Hospital, they have found that the endothelial cell loss in both the groups is similar. However, if you look at the visual recovery, you find a greater percentage of patients having 20/20 or better and a faster visual recovery. So you can see that day 5 post-op, one of my cases, the patient is already seeing 6/6. This is again a patient, one eye DSEC done, the other eye DMEC, and you can see the eye with the DMEC, the patient always feels that the quality of vision is better. And this is a DMEC done in one eye. The patient was so happy with the first eye surgery that within a week we went ahead and did the fellow eye DMEC surgery. And that's because of the patient's comfort and the visual recovery that you see. This is a 3-year follow-up, uncorrected visual acuity, 6/9, minimal cylindrical power, cell count is pretty much same as what you see in a DSEC case. The biggest advantage that DMEC has is looking at the endothelial rejection rates, and in this, the 1 and 2 year rejection rates for DMEC was only about 1%, whereas it was 8 and 12% for DSEC and 14 to 18% for PKP. So basically DMEC had 15 times lesser risk compared than DSEC, so I need to use lesser steroids for my patient. If my patient is less compliant, the risk of endothelial rejection is much less. So for me, this is the biggest point where DMEC scores over any other type of endothelial keratoplasty. So why DMEC scores over DSEC is basically that the corneal anatomy is better maintained. You have a faster visual recovery. Obviously, your patient wants a faster visual recovery. The greater percentage of patients seeing 20/20 or better, the quality of vision is better. You see a reduced hyperopic shift. So if you're combining it with the IOL implantation, maybe you have greater predictability. And there are surgeons who claim that with DMEC, they're even doing toric IOLs and multifocals, which I haven't done so far. And the reduced risk of endothelial rejection is definitely one of the biggest plus points for choosing DMEC over DSEC. Thank you.
Thank you, Dr. Fogla and Dr. Titial, for a very interesting presentation. The first question to Dr. Titial, has your shift towards DMEC increased over the last 1 or 2 years?
No,
And forget about your...
I can answer in 2 frames. So yeah. One is looking into literature. There's a shift towards a DMEC across the world. And if you look at US studies, people are graduating to more of a DMEC surgery than DSEC as such. As far as Indian scenario is concerned, there are few surgeons who are doing now much more DMEC than a DSEC, like Basak is sitting here and a Fogla. We have just got into a DMEC surgery 2017 as such, just 1 year, 6 months plus now. And we started doing DMEC in our center also, and we are shifting towards that also. So we know that it's a better physiological surgery. We would like to go for that surgery given the option if things are well oriented from a surgeon's point of view and patient point of view. So there's no doubt that DMEC should be done in all these cases.
So can we say that there is something like a fear factor, and if you overcome that fear factor, probably, and when you become more and more experienced surgeon, people become more comfortable with DMEC?
That's true. One thing we have to understand, DSEC surgery and DMEC surgery are two different surgeries. You have to unlearn the DSEC procedure, then do a DMEC. So a person who is doing a lot of DSEC, it may not be true that he'll do a DMEC within a go. So you still require a learning curve of DMEC as an experienced DSEC surgeon also. So that is what we have found out. It takes almost 20, 30 cases to feel you are comfortable. But one fear I had, Dr. Basak is my teacher in this regard. I always had a fear. I thought major challenge is scoring the Descemet's, peeling of the Descemet's membrane, which subsequently I realized that's the easiest part now. The actual opening inside the eye and orienting the graft in proper manner and centration is the challenge nowadays for us. So things change very fast as you do more surgeries. But yes, given an option, you have a tissue. Sometimes I have a patient in the ward lying down for 1 week, but I don't get a proper donor at that time. That's a major concern at this time in our center. There are areas where you get a CDS system where you get a tissue as per your patients. Then it's easier. So that's a two scenario. If I have a patient, I have a tissue, maybe I'll go for DMEC for all cases.
Thank you very much.
Yeah.
So I would once again appreciate Dr. Titial to make this very, very frank statement, not just harping on the topic given, but also equally sharing his views. Rajesh, question to you. The common criticism against DMEC is you may be wasting tissues. And Dr. Titial alluded to that fact that he is little bit concerned that the scoring of the tissue, at least in his initial thing, was a rate limiting step.
Especially younger patients, yeah, you do have difficulty, and unscrolling of a younger tissue is also a difficult scenario. People do even a 30, 40-year-old donor.
Yeah.
So sometimes it can be very difficult, challenging in a difficult situations.
Yeah. What's your take on that with regard to utilization of tissues?
Well, in the initial part, there is definitely a learning curve. And once you do a significant, at least 15, 20 tissues, if you have prepared yourself, your tissue loss rate should be less than 1%. And even if you did damage the tissue when you're peeling off the Descemet's, the tissue is not wasted. You can still use it for a DALK surgery. And
that's
most of the eye
point,
banks,
your patients for endothelial keratoplasty, not for DALK,
but right now, we may be moving to a point where your eye banks will give you pre-stripped donor tissue. In the US, you get pre-stripped, pre-stamped donor tissue, which are already in the injector. So all the surgeon has to do is to take it, and you can straight away go ahead and insert. So I was doing some surgeries in Kuwait recently, and they had imported the tissues from the US, and it was such a smooth and easy thing that you just go to the patient's eye, just do that, and you don't even have to worry about stripping your tissue. You have a preloaded DMEC tissue, you just take it and you shoot it into the eye and be done with your surgery. Yeah. So we are moving toward that. I think the LV Prasad Eye Bank is already looking at the prospect of giving you pre-stripped tissues for DMEC surgery. So I think the comparison between a DSEC and DMEC would be like comparing extracapsular cataract surgery and phaco. So there is a transition phase. People did face little resistance, and I think it's a learning curve. And
yeah, so thank you very much. We'll have Dr. Basak to give a short.
Just regarding that, not only DALK, even you can rescue those tissue in halfway. Hemi-DMEC is available now. Quarter DMEC is available. And also I have used in two scenarios. I converted to DSEC because we are initiating with 9.5. So we have plenty of tissue. If you have multiple radial tear to initiate, you can just shift it. So that is one thing. And otherwise, Rajesh is...
Any other comments from the audience before we move on to the next?
How many people are onto the DMEC surgery here?
With regards to surgeons learning DMEC, if you look at LV Prasad Eye Institute, I think they started doing DMEC very recently in the last 2 years, and most of their surgeons have, gone through the learning curve, and I think they are quite comfortable now doing DMEC.
Any comments? Okay, so this is a very evolved audience. So this audience need not be told by this panel that one surgery is better than the other. I'm sure you would use your intellectual maturity to decide what are the merits and demerits of both the procedures. I would like to thank both the presenters for a very, very nice presentation and also a very diplomatic way of presentation. I think that's the way the debates should go rather than really having a wrestling match out there. Thank you very much.
Thank you.
I would now ask my co-chairman to initiate the next series of talks.
Moving on to, good morning everybody. Moving on to our next topic. It will be on fungal keratitis. We have Dr. Namrata from RP Center speaking for intrastromal voriconazole in severe non-perforated fungal keratitis. Dr. Namrata, please.
So Prashant said that he couldn't really face up to me, so he couldn't come. So my debate is already over. And for this case, what would the House do? Very frankly. What would you do, Murli, since you have to, you would obviously do a therapeutic PK, but it's really not required. It's not coming, the image. Okay, so these are the cases that we published, and for this was in fact the first case for which we did intrastromal injections, and this is how it responded. So we didn't have to do a therapeutic PK at all for this. Now intrastromal voriconazole gives you, or intrastromal injections give you a window of opportunity to avoid PKP. They give you a more targeted drug delivery form of a system, and the antifungal therapy reduces the recurrence rate. And of course, therapeutic keratoplasty can be done in cases of perforations. If you see, the anatomical success rate is although 88 to 84%, but functional success rate can be as low as 5.6%, and plus there's always a chance that there could be recurrence in 12% cases. This is the paper we published to compare topical and intrastromal voriconazole, and we found that both of them work equally well when you add intrastromal voriconazole as well. And this is the protocol that we follow, and this protocol works well where we have intrastromal injections in our armamentarium. And I don't have to really prove my point. There are so many case series, so many studies which say that intrastromal voriconazole works well. And if you combine all of them, almost 85.7% of the ulcers healed in these case scenarios. Now, there are so many papers and papers after papers highlighting the same, and so many cases that I can show you which have responded to intrastromal injections without actually having to do therapeutic PKP. And even vascularization is not going to increase if you do that. And the technique is quite simple, and again, these are just cases which just prove my point without having to actually say anything. How the ulcers they heal. Now this was post LASIK fusarium keratitis, intrastromal voriconazole was given, and again it has healed without actually having to do a therapeutic PKP. And now what evidence would you want more to say what you would do in these cases? And look at therapeutic PKP, it is fraught with complications, loose sutures, suture-related infections, persistent epithelial defects, endophthalmitis, graft rejections, hemorrhage, and the most ominous complication. You have an open globe there, and what do you do? That there is expulsive hemorrhage that occurs. Now all these complications cannot and will not occur with intrastromal injections. And of course you don't want to land up in a complication such as this. I'm sure none of us in the house wants to do that. And even if there is a recurrence, and look at the recurrence rate with therapeutic PK, you can have recurrence with this as well. And there are so many cases, as you can even have endophthalmitis with therapeutic penetrating keratoplasty. And even if there's a recurrence after TPK, your intrastromal injections are coming to rescue. So what more do you want after that? So to conclude, intrastromal voriconazole is the way to go in cases where the infection is recalcitrant and is not responding to medical therapy. Thank you for your attention.
Thank you, Dr. Namrata. Very relevant points. One question which I have is, earlier we used to use intrastromal amphotericin B, and then we have shifted to intrastromal voriconazole. So how do you rank both against each other?
No, not just now. Very recently, one of our students have finished a thesis on intrastromal voriconazole versus intrastromal amphotericin B versus intrastromal netamycin. And netamycin is the soluble one, so it is netasol. And we found that intrastromal netasol works the best, followed by intrastromal voriconazole, followed by intrastromal amphotericin B. Amphotericin B causes a lot of reaction.
Another quick question is, you have been using oral voriconazole also as of now, and you're probably working on it. How would you rank that against intrastromal voriconazole in such florid cases of fungal keratitis, wherein we think in some time they would be needing therapeutic PK? So in those cases, how do you work on intrastromal voriconazole and oral voriconazole?
See, if I showed you that slide which completely showed the algorithm which we have been following, and we've done almost now 350 plus cases following that algorithm, where we are the algorithm is very simple. If the ulcer is more than 6 millimeters in size, more than 2/3 in depth, we would go in for systemic drugs along with the topical netamycin that we would include. And the idea of doing that is that when the ulcer is large, another study I think which we published also in Cornea just 3 months ago showed that systemic voriconazole, the tear levels as well as the plasma levels are much higher when we compared it with ketoconazole. Of course, in that group, we didn't have a group where we gave no systemic drug. So that was the thing. But it does help because we can extrapolate that because the tear concentration of the voriconazole is higher as compared to ketoconazole. So that really helps in healing of the fungal keratitis. And intrastromal, again, we are now modifying it a little bit because the paper that we published had mild to moderate cases. So we used intrastromal voriconazole for more lesions which are moderate, not severe ones. And probably that is why when we compared it with topical voriconazole, we found the results to be similar, not any better. But I think that because the lesions are not any deeper, so intrastromal will not give good results there. But if you do it in more severe cases, which we are doing now, intrastromal it does give better results. And I think even Arvind is going to do a randomized control trial now of intrastromal drugs vis-a-vis no intrastromal antifungal agents.
Thank you, Dr. Namrata. We would move on with Dr. Muralidhar from LV Prasad Eye Institute, who would be speaking for therapeutic keratoplasty in non-resolving fungal keratitis.
Murali is considered even before speaking. He's come to my side only.
So,
no, I'm not switching sides. Thank you again for having this opportunity. I'm representing Dr. Prashant Garg. I do not have any financial disclosure. So there are numerous studies which have already highlighted the topical netamycin is the drug. It is a gold standard currently. And you don't have any distinctive advantage by combining other medications. And even Dr. Pragna would agree with his elegant paper. And a recent Cochrane database also showed netamycin is a superior alternative, at least in this part of the world. And by adding, voriconazole can have a synergistic benefit, particularly in a recalcitrant cases. And Dr. Namrata has proved in our elegant paper, you don't have any distinct advantage pushing the voriconazole intrastromally. In addition, it needs a repeated injections. To me, repeated voriconazole, it induces so much of intrastromal, inflammation. It invites vascularization, and we could see clearly in most instances, as Madam actually showed, they end up having a lot of vascularization. This would actually directly influence the prospect of future optical grafting. So those cases which are recalcitrant, it would be prudent to consider expedited therapeutic graft, wherein you can get a 360-degree macroscopic clearance at least that minimizes the risk of recurrence, and prospects of future DSEC and DMEC are much good in these cases. This is one example wherein we delayed the surgery by resorting to the multiple intrastromal repeated injection, end up doing a large therapeutic graft and had a poor outcome. So even if you have a primary graft failure following a TPK, now you have an option of doing a DSEC or a DMEC, can end up having a good results. I would urge, expedited TPK, you can even use a optical quality tissue in cases to have a much better visual outcome. So therefore, our algorithm is anything which is a recalcitrant instead of opting for an intrastromal injection. So the early therapeutic PK end up giving a good anatomical as well as a functional outcome. Thank you. I open this debate.
Thank you, Dr. Murali. Anybody would like to comment on for or against any of the topics?
I have a question to Dr. Namrata. So how would you optically, rehabilitate these cases which had intense stromal vessels all around?
I just wanted to, in the study, if you read where we did compare intrastromal voriconazole vis-a-vis topical voriconazole, we did compare quadrants of vascularization, because this thing was there in our minds that because we are giving intracorneal injections, so does vascularization increase or not? And we did compare quadrants of vascularization and the depth of vessels, and we didn't find any difference between the two groups. So that was there, but yes, I would agree on one point, and I think this could be yet another study, that you could compare what would be the outcomes of optical penetrating keratoplasty in those cases where you gave intrastromal injections vis-a-vis in those cases where you didn't give intrastromal injections and just those cases healed on topical medications. So would you actually increase or decrease the graft? Rather, would you actually decrease the graft survival on those cases or not? So this could be yet another thing, which could be studied in a prospective manner.
Besides the systemic, whatever we are giving?
For endoexudates.
So for endoexudates, what we tend to do is, suppose there's a abscess and endoexudates both, we are going in and doing intrastromal injections. We would give intracameral and combine intracameral and intrastromal. That is something which we are doing very, very often. The only thing is that if it is just an intracameral endoexudate, then also it makes sense, because it also gives you some amount of material for your
culture
microbiology.
Yes, ma'am.
So it does make sense. See, with Amphotericin B, it was a little different because that caused more reactions, but voriconazole doesn't cause that much reaction, and letasol that way is the most friendly one. The only flip side is that it is not available commercially.
And so it's more of a, obviously I'm on Murali's side. And
obviously you're on my side. So.
As well as your side. So I was just trying to point out that there are a few cases where we have injected intrastromal voriconazole and we had success. I think these cases are more where the central infiltrate is improving, the scarring, but there are a few satellite lesions closer to the limbus. And these cases are the only ones where we really had success. And sometimes we wonder whether it's because of the blood vessels being there and it's close to limbus, whether that is also working, that has some additive effect, along with the voriconazole, along with the topical and maybe oral treatment.
See, the problem is that if you say natamycin works and natamycin works and natamycin works, I agree.
No,
but what when you give natamycin, it doesn't work? Then you have to give topical voriconazole, doesn't work. Then you try intrastromal, doesn't work. Then you do a therapeutic PKP. And another thing is that intrastromal injections should be given earlier than later. I mean, they can't be just, in the last mercy case, okay, tomorrow I have to take the patient up for therapeutic, so let's try intrastromal. It can't be like that. So there is a period in which it has to be given if your ulcer is, say, more than 6 millimeters, more than 2/3 in depth. At that point in time, I think it does work.
So that brings to the second point, is the referral base. So we have ulcers coming in with much later on. That's the reason why we resort to.
Yeah.
We can't have the luxury of doing anything else but a therapeutic PK.
So thank you very much. We go on to the next presentation.
We'll be now moving on, slightly different from the order, to the high-risk graft debate. Dr. Prateek Teotia would be talking about systemic immunosuppression
in a high-risk graft patient. We're a little behind time, so I would request Dr. Rishi Swaroops to also be ready.
Three minutes.
I have only 6 slides, so I'll make up for him.
Good morning, everyone. I will be speaking on systemic immunosuppression in high-risk graft. First of all, I would like to thank the organizers for giving me this opportunity. Next slide. Yeah. So corneal transplantation is the most common and successful form of organ transplantation, and 10-year survival rates of corneal graft range between 75 to 80%. However, in presence of high-risk graft, it reduces to 30 to 50% at 3 to 5 year follow-ups. The high success of corneal graft has been attributed to immune privilege of the eye. Next. And rejection mechanisms of corneal allograft represent a delayed type of hypersensitivity response, predominantly mediated by allospecific CD4 T plus cells, and most common reason for graft failure is endothelial cell rejection. Eye is considered at high risk when vascularization of 2 or more quadrant is seen, extending at least 2 mm into the stroma, or previous graft rejection in the affected eye. Other studies have considered graft close to the limbus and simultaneous limbokeratoplasty, patients having severe atopic dermatitis or herpes simplex keratitis at high risk of graft rejection. In these cases, apart from topical drugs, we need to use systemic immunosuppressants. Though clinical studies have shown improvement of graft outcome by administering systemic oral steroids, steroid treatment alone is not advised in the long term due to side effects. Immunosuppressants prevent corneal graft rejection by inhibiting the immunity of the host, and various immunosuppressants used are cyclosporin A, mycophenolate mofetil, and tacrolimus. Those systemic steroids are most commonly used, but they have systemic side effects such as osteoporosis, weight gain, and Cushingoid features. Shimazaki et al. Studied cyclosporin A in high-risk grafts, but they found that no positive effect of systemic cyclosporin A administration for suppressing rejection in these high-risk grafts. Mycophenolate mofetil treated patient showed fewer side effects than cyclosporin A treated patient. The side effects were attributable to both drugs were reversible. Joseph et al. Studied tacrolimus at a mean dose of 2.5 milligram, and they found that it was relatively safe and effective in reducing graft rejection and prolonging graft survival in high-risk patients. Newer drugs like rapamycin were also studied, and it was found that combined treatment with low-dose cyclosporin A and rapa resulted in superior graft survival and effectively modulated the messenger RNA expression of inflammation and infiltration markers. A Cochrane review on immunosuppressant for prophylaxis of corneal graft rejection found that the current evidence on the effect of immunosuppressant in the prevention of graft failure and rejection after high and normal risk keratoplasty is largely of low quality because the number of trials was limited and better studies are needed to prove its utility. Thanks.
Yeah. Dr. Rishi, please.
Thank you, Dr. Pratik. Okay, I'll have to.
So you are coming to my side?
So you made a good attempt. You just told us about immunosuppressants which are used in high-risk grafts, but why you should be using, I don't think you made a compelling argument, and I'm going to just try and counter you. Slides are not coming. You started my timer. Yeah. Okay. So I'm trying to convince you that high-risk grafts, just stick to topical therapy. It's just not worth it going for immunosuppression systemically. It's not moving. Okay, yeah, no problem. So high-risk grafts, we know what they are, increased, those which have high vascularization, large grafts, eccentric, pediatric, and repeat grafts. These are all difficult cases, and we know they have high propensity for failure. Next. So why you should not be using systemic immunosuppression? 3 C's: cost, compliance, and complications. All 3 are major problems, especially in our country, in India, where patients don't have money to come to the hospital, and then you're going to add the cost of immunosuppression to them. And you know how much compliance we have. We don't not even 20% will complete few months of therapy. So it's most futile in majority of the cases. Yes, some selected cases, well-off patients who are educated and are likely to follow up. I'm not saying don't use in those, but for majority of our patients, I don't think systemic immunosuppression is really worth it, because we know they will not complete it. And the complications sometimes can be devastating and can even be lethal. So whether it's the risk-benefit ratio is worth it, we still don't have the answer. Next, please. So we know that rejection can occur anytime after keratoplasty, even after a decade it can happen. So till when will you keep giving them systemic immunosuppression, right? That's something we have to think about. Again, the 3 C's come into play. If you're going to give for 5 years, how much will be the cost, what will be the compliance, etc., etc. There have been alternatives in topical therapy, especially systemic topical tacrolimus. There have been some encouraging results from some of the reliable groups, including from Dr. Dhaliwal's group. And in my own practice, I use a lot of topical tacrolimus, and I found that ever since I started using them, the number of rejections in high-risk grafts have significantly come down. Although I have not really looked at the data in a proper way, but bird's eye view, I can tell you that it certainly helps, and helps to cut down the number of rejections. Next, please. So this is the clincher. This is the Cochrane database systematic review studying the immunosuppressions for prophylaxis of corneal graft rejection after penetrating keratoplasty. And this is one of the statements. Current evidence on the effect of immunosuppressants in prevention of graft failure and graft rejection after high and normal risk keratoplasty is largely low quality, because the number of trials was limited, and in general the trials were small and at risk of bias. Future trials should be large enough to detect important clinical effects, conducted with a view to minimizing the risk of bias, and they should measure outcomes important to patients. So essentially all the studies with Pratik listed are of no use, because the systematic review has told you that the data is really not significant enough to draw useful conclusions from them. So until we have solid evidence, there's really no point subjecting our patients to the 3 C's: cost, complications, and compliance problems.
Thank you.
He copied my slides.
So I think this is still a debatable topic. Dr. Rishi, if you get a patient who's operated elsewhere with a failed graft from rejection, it's a second graft, and he's on systemic immunosuppression, and he says he's not tolerating it very well, would you substitute the systemic immunosuppression, or you feel confident enough to stop it? Because the usefulness in your mind, or in a lot of our
So if he is not tolerating it, and if I don't think that he's going to be likely to be compliant with the therapy, I will discontinue it and
no, he's
step
willing to
up.
be compliant. You can shift from, say,
If he's willing to be compliant and he's already there, that's not a problem. I'm saying majority of our patients will not be compliant. So you see the patient and decide, but 80%, it's really of no use. You also know it. Everybody who's practicing cornea knows that immunosuppression is a big challenge, especially in India.
And with systemic side effects.
Yeah, and systemic side effects, he's also telling.
Yeah.
I can't help him, he decided to lose the debate.
I'm favoring Dr. Rishi on this subject. But yes, in some cases we need to immunosuppress the patients, and risk or cost-benefit ratio have to be seen before starting the patient on immunosuppressant.
I would put them on topical tacrolimus.
Okay.
But there are no long-term studies on topical tacrolimus.
They're as good as the other studies.
Yes, yes. So.
Afferent arc and an efferent arc, and in a high-risk graft, the vessels, lymphatics, the afferent arc is already there. So all our effort is in suppressing the efferent immune reaction, which a systemic immunosuppression is likely to suppress the efferent arc. How will a topical drug suppress systemic response or immune response? It is okay for a maintenance of a primary graft, but for a high-risk graft done 3 times, when the afferent arc is already well established, can we really expect a topical drug to work as well as a systemic drug? In theory.
It's just theory.
In fact, the paper by Dr. Dua says that sometimes in a high-risk graft, you have to take a high-risk eye graft similar to a liver transplant. That is how the role of systemic immunosuppression was actually theoreticized. Practically, I don't think we've reviewed it enough in terms of the same surgeon having so many high-risk grafts to do an RCT. But, so the debate is still open. Can we have someone say the last word?
If I know my patient has a high-risk graft, requires immunosuppression, I should be doing surgery with the immunosuppression. So we are bound to have a failure in that case. And subsequent question will be, why do you do a surgery in such patient where you are such a high risk? How do you justify that?
What if the patient dies from side effects of it? That also becomes a legal implication for them.
It's a high-risk graft. Then why should I jump into doing surgery in that patient if I cannot immunosuppress that patient?
Fair enough. So then you just discourage the patient from surgery if you think that they are.
No, but we get a lot of follow-ups also who are high-risk grafts on systemic immunosuppressants. So just because we don't want to manage immunosuppressants, we may still have to manage someone who started and we may not want to stop it.
Can I have
so in such a case, you may want to choose a keratoprosthesis.
Yes,
yeah.
That is the choice when the patient's life is at stake.
Yeah.
So why you are talking all this? So go for keratoprosthesis and explain all the pros and cons of keratoprosthesis, and long-term keratoprosthesis result is still going good.
I think we have a talk on keratoprosthesis.
No.
I think I would request Dr.
Boston
Somishila to please
one I am
comment
talking
on
about.
Sir, but I think I did only 1 keratoprosthesis in a private practice, and that patient did 6 for 2 months, and I had to eviscerate him because because he came with a very bad infection, and there are some disasters that happen that put us off in a private practice. No, I absolutely agree, sir. But does everything has.
I wanted to point out that exactly as Shreyas
we
said.
have a talk on keratoprosthesis.
I think, if you have a high-risk graft,
so
you have to always judge the
Ritika
patient.
and Dr. Basak have already argued the
can take immunosuppression, we should give a immunosuppression. Take a help of a proper internist or a medicine person to handle that case. We need to have that. Otherwise, we are at risk sometimes. Tomorrow, I'll be, pulled in the court, said, you knew that this is a high-risk graft, why did you do without immunosuppression? And topical one is not an immunosuppressant, just a maintenance or just a...
steroid sparing. Basically, topical are for steroid sparing side effects.
Thank you.
Thank you.
Thank you for a great debate. We'll move on to the next debate, which again is partly a legal issue as much as a clinical issue. Managing progressive keratoconus in pregnancy. Shreyas will be talking about the wait and watch approach, and Dr. Kavita will be taking up the cross-thinking during pregnancy approach.
Good morning, one and all, and it's a pleasure and privilege to be talking in front of such a learned audience. So the question posed today, would you do cross-linking in pregnancy? And I would most certainly say, let's wait. Is CXL harmful during pregnancy? This is probably the first question anyone is going to ask, and my opponent is going to ask as well. The true answer is, we don't know. Clinical acumen might tell us that it's probably not going to affect the pregnant lady or the fetus. But then we don't have any compelling evidence, any studies showing the outcome of cross-linking done in a pregnant woman. And then the medical legal aspects as well, which we are all very well aware of. So before we really go analyzing the safety of CXL, let's really look at the risk of progression in pregnancy itself. Keratoconus progression in pregnancy, a lot of hormonal implications, not very well understood, but at least relaxin is one of the major hormones implicated in this. And the peak of relaxin hormone is only during the last few weeks of pregnancy. And we could easily wait and watch those last few weeks and do the cross-linking once the woman has delivered. So subsequently, The next thing is, how much does actually keratoconus progress during pregnancy? Studies have shown that on a mean, in a pregnant woman, the increase is about 1.4 diopters in the SIMK and 1.1 diopters in spherical equivalent with no change in the RGP which they were already wearing. This 1.4 diopters in SIMK is just barely above the test-retest variability of an OBSCAN or a pentacam in a keratoconic patient. And these 1 diopter flattening which we may require, whatever increase has happened during pregnancy, can easily be done by just a cross-linking alone, which can be done very well after pregnancy. And what we really must ask ourselves is, we have shown topographic progression, but is that really clinically relevant to a pregnant mother who cares about nothing else but the child in her belly? Is the progression even permanent? Dr. Hafezi has shown that in studies that these are often transitory changes which are reversible once pregnancy and lactation wears off, and much of it reverses. Not only this, increase in curvature, decrease in pachymetry, myopic shift of up to 0.9 diopters is reported even in a normal non-keratoconic eye. So keratoconus in pregnancy, minimal progression, potentially reversible. You may have a topographic change, but then is it barely clinically significant for the mother? And let's avoid all medical legal aspects. If the child is born with some deformity, it's natural for the mother to think that this is, it could have been contributed by the cross-linking done during the pregnancy. Could she have just kept calm and just waited? Thank you.
Dr. Kavita, please.
Can I have my slides, please? So I'd like to start with saying that this definitely is a gray area, and I haven't done any cross-linking in pregnant women. But I'm going to just break this down stepwise. I think Shreyas has already alluded as to why progression and establishing to progression, whether cross-linking is safe, and what would be the indication for cross-linking in a pregnant woman. Now, why progression? What happens is that we all know there are estrogen receptors in the cornea, and the number of estrogen receptors goes up in pregnancy, which then stimulates the production of prostaglandin and collagenases, which then decreases the corneal rigidity, and that's what causes the corneal ectasia. There are various reports which are showing the pregnancy-induced progression. There are, these are the patients where they found that 4 patients where, like he said, there was an increase of only around 1.5 diopters, but this patient had a much more significant increase in the keratoconus, but it was only a topographic increase, as he has already pointed out that there was no pachymetric thinning in this patient. Now this was a case, these were a few cases reported where there were post-LASIK ectasias by Hafezi, and they were as far as 9 years after the corneal refractive surgery, where he has said that it is definitely the pregnancy itself which has caused the post-LASIK ectasia. Now, establishing true progression, is this real progression, or is it just that the pregnancy-induced changes are causing these false changes in your corneal topography? This was a paper which has been presented by Hafezi itself, where he has presented 2 cases, and what he has shown is that these cases, both of them actually, they got better. At the end of pregnancy, the corneal topographic values came back to normal, but in both of these papers, there is no mention at all of pachymetry, whether there was any thinning, true thinning. There was a reversal of the topographic changes which was seen. So what is important is to know whether we are going to establish the progression which is true or not. Now let's come to the next point which he talked about, getting any changes in the fetus or having any complications in pregnancy. So is cross-linking safe or not? First, let's understand the UV rays. The UV rays which we are using in cross-linking is the UVA ray. It is a non-ionizing radiation which is different from the ionizing radiation, which is the far ultraviolet rays, which causes complications. So this is not going to cause any complications. In fact, there is a paper which has been reported by Dr. Shetty, in which they have studied how much radiation does the surgeon get exposed to, and they found that it is really negligible, especially with the gowns and the gloves especially that we are wearing. And in fact, what he had concluded, it's going to take multiple years of doing the cross-linking every day on patients for us, like maybe 100, 150 years for the surgeon to actually be affected. So now that we've established that yes, it is safe for the fetus, whether we should be doing it or not, like I said, we need to establish there's a true progression with the corneal thinning. And of course, if there are any sight-threatening complications, I don't see any harm in going ahead with the cross-linking. This was a paper presented where they found eye drops which resolved faster after doing cross-linking. Of course, the social, medical, legal concern is there. If you're going ahead, it's important to take a consent, explain to the patient, of course, make sure that the patient is completely fit, which we may not do with a routine, when we don't really look at the systemic conditions so much in other keratoconus cases, but here it's really very important. And make sure you treat the patient well post-operatively and heal the epithelium. Thank you.
Thank you, Dr. Kavita. So I think this is more about a preferred practice pattern, more of a legal issue. So can we just have a show of hands as to if a pregnant lady comes with keratoconus, which you know is progressing, you have a previous baseline, and you have a significant progression, how many of us would cross-link that lady?
Thank you.
Okay. So I think it's a medical legal issue as of now, because it is contraindicated on paper when you are looking at cross-linking. Even on literature, it says that pregnancy is a contraindication because they don't know the effects. And though there are case reports in literature, there was a lady that they cross-linked who developed an infection, which actually was severe enough for them to give systemic therapy in terms of antifungals and antibacterials, which then became contraindicated in pregnancy. So though they felt that the cross-linking would not have had any teratogenic effect, but they could not handle some of the ramifications. So you never know what ensues, but practically it makes sense to cross-link a progressive stage, but because of the medical legal issues, I think we're all wary of.
No, I agree. Medical legal is one thing, but if it's going to be sight-threatening, if you're going to save vision, say if there's a patient with a pregnant woman with phacomorphic glaucoma, you are going to treat that patient, you are going to do the surgery. So if you think that there is going to be threat to the sight, like in this case, specific case where they showed the eye drops did improve. So I think this is definitely open to debate. It's not really been established that.
I think that's the exact point here. Phacomorphic glaucoma is an emergency. Whereas keratoconus, we've seen in all the studies published, you yourself reiterated that point, that the progression is hardly 1.5 diopters on topography. So is that really worth? It's not really sight threatening. It's not even altering the RGP fit. Unless she comes to you for a checkup, the mother may not even know that her keratoconus has progressed.
No, I'd like to counter that. In fact, a report which was by Dr. Hafezi, out of the 2 pregnant women, one of them, it took her 2 years to come back to the pre-pregnancy topographic values, and she had poor vision for 2 years. So that also is debatable whether you want to keep the patient with poor vision for 2 years.
So thank you. We'll move ahead. Shreyas wants to make the final word.
That's fine. Thank you.
Okay. We'll just move ahead to the next debate because we're running short of time.
So the next debate will be on CHED. But Dr. Samar Basak will be talking on DSEC is the way to go when you treat a patient with CHED. Dr. Basak. Your choice, sir.
This side.
Can we have the mic, please? Can we have the mic, please, Danya?
So, there should not be any debate on...
Sir, sorry, sir.
The mic is not on, now on. So, there should not be any debate on DSEC in shed versus PK in shed. I do both depending on the severity of presentation. That is the case. So what should be the management? This is a bilateral shed with Salzman nodular degeneration. Patient is 6 years male. The DSEC or PK. So if you, I did in 2 steps. First I removed that SND. Then if you see the corneal thickness under slit lamp, you see that left eye is a better eye for DSEC. So I did dissect in left eye. And this is the picture, 3 months post-op, the child 624. So surgical choice depends on severity on presentation and surgeon skill and experience. So here is another example, 4 years male, bilateral, and you see that even the corneal thickness in both the eyes are different. And again I choose the left eye, and left eye this dissect is going good, though little haze, it takes long time to clear, but you see that after 4 years this graft is still surviving with a vision of 624. So this is the other eye of the second patient. You see that right eye I tried dissect, it never cleared. So I had to go for PK, subsequent PK, and the astigmatism of 7.65. But I didn't have any other choice. So this is another case where the PECI is more than 1000. It is 1200. The choice is of course PK. So pachymetry is one of the important tools. If you do it, it is the best thing. So this is another patient. If you take the both eyes, the PECI shows the left eye is 805 and the right eye 1050. So choice is clear. For the right eye, I will go for PK, and for the left eye, I will go for dissect. So we know the all pros and cons of dissect and PKP, but the choice, whenever I get a chance, the choice is dissect. In PK, failure, regraft, and then more failure, and then this is a child from RP center. There the surgery was done for 5 times. 5 times within 6 years, and the parents are not willing to touch the left eye. I did Boston Capro in this eye. Down the line 2 years, the patient is having 6966. Thank you very much.
Not only does Vanathi have a choice, so even Somshila Murthy, that debate also is gone. So we will now ask, I'm really proud of our cornea colleagues, you know, debate just not for the debate's sake, but everybody talking about their choice. Dr. Vanathi.
Yeah. Thank you, Dr. Prajna. And I think I'll have to start stating my consensus on what Sir started on. Yes, I think we can do both DSEC and PK in chair. Yes. But then just hear me out, please. Okay. So let me take it point-wise. So here you're seeing 2 cases, and CHED is a disease where the presentation severity or the morbidity of the disease significantly varies. So your decision to do a DSEC will depend upon the visibility of your maneuvers in the anterior chamber. So you're seeing 2 cases side by side, where you see the first is just not going to be dissecable, and in the second you still see there is a hampered visibility, and you could go ahead and do a DSEC. But then of course the surgeon's experience is going to matter a lot in giving a successful surgical outcome for this case. And again, in these cases, I think in LVP and in most cases, they are still doing DSECs even when the corneal thickness is about 1000 microns. But the visual rehabilitation time period is going to be much higher and longer for these patients, and it's almost going to equal the 3 months or more period which you need for visual rehabilitation as in penetrating keratoplasty. There is a significant technical difficulty in doing DSEC in CHED eyes, especially in younger children and infants. They are phakic eyes. You have lesser space to manipulate with, and you have to use your technique variation and use the iris undercover for all your manipulations during the surgery. Again, as I told you earlier, the time to visual rehabilitation is lesser when you do DSEC in CHEDs, which are relatively clear, and when your corneal clarity preoperatively is much lesser. But when you do DSEC in cases where corneal clarity is much higher, your time to rehabilitation is going to be much longer, and it's also going to be as equal as that when you take to do a PK in a CHED. Graft dislocation deviations can be higher in pediatric eyes as compared to adult at D6, and it has occurred in one of my cases. The child rubbed, and I had to take the wait for 3 days to get an optical tissue to do a PK for the child. The cornea went in quite white before I could do a resurgery for this child. And again, you probably need the help of IOCT to do difficult maneuvers. Even your your Desmet scoring is going to need an IOCT peeling to be sure when your clarity is not going to help you. That's one other scenario where a PK probably will score over in a case of CHED, depending when the clarity is not going to allow you. And again, as Sir rightly pointed out, when a DSEC graft fails in a CHED, you're probably missing a glaucoma associated with CHED, which is probably responsible for the failure of the endothelial graft in this particular patient. So you still have the problems of cataract formation, pupillary block glaucomas, graft displacements, which are going to alter your decisions. Again, a patient of mine, as Sir showed, one-eyed I had done a DSEC, the other eye went to PK, and you can obviously see the PK eye always looks much clearer and much better, but does have the problems of rejections and the problems of inherent to PK itself in this particular, and astigmatism as well. So to conclude, I will again say, I'll point to what is now evolving as evidence, or the reclassification of CHED, where we've looked conventionally as CHED1 being autosomal dominant and CHED2 being autosomal recessive. Now the newer ICO classification has totally removed CHED1, and it no longer, CHED is now only what we earlier called CHED2, the autosomal recessive, and much of it has been mapped to the chromosomal 20 loci 20p13, and most of these pedigrees are coding towards the sodium borate transporter deficiencies. So what we had been doing as CHED1 earlier, which was the most dissecable cases, are probably cases of PPCD, which are seen to be as a variant of a PPCD, which has now been electron microscopically proven. So CHED2 is the CHED which we are looking at now, and this is a more severe form of TED, and the clarity is much compromised in these cases, and you perhaps need to do only PK for these cases. With this, I would like to conclude, and thank you for your patient hearing.
Thank you very much. Dr. Vanathy, one question. Dr. Basak showed cases of PK being done for CHED. Do you have any, have you done EK at all in patients with CHED?
Yes, I have.
Okay, so both yes. people have done both procedures. Yes. And
that's why
there should not be any debate on this.
That's why I started off saying it is probably.
That's a nice thing which we have to tell the audience. As you rightly pointed out in your first slide, sir, it really depends on the cases which you are going to do. Any parting comments, Dr. Basak, since you both are so friendly, we're just going to give you an opportunity to give any comments to compliment Dr. Vanathy on her.
Same. She said the same thing, but PK, the problem is in the child, the failure long-term, 5-year survival, hardly 30% only.
Are you concerned about the amblyopic part which she was trying to bring out, saying that...
For DSEC or for PK?
For PK.
For PK, yes, amblyopia, visual rehabilitation is far more difficult in PK.
Okay.
Difficult,
Sir,
yes.
I agree,
the astigmatism, how do you address
penetrating keratoplasty in CHED, you have to do it when it is, the cornea is so thick that you can't do an endothelial keratoplasty. And today we have genetic evidence also that DSEC is probable for those cases which we considered as CHED1, and which is probably moving into the gamut of PPCD.
No.
But when you're doing PK, you do have your problems of rejections, visual rehabilitations, they are definitely there. But again, CHED has a longer, I have a lot of CHED patients who have associated myopia with them, and amblyopia per se, it's not only because of the keratoplasty, but it's also because of the associated refractive error, which has gone untreated for a longer period of time. Significant 30% of the patients also have glaucoma, which is pre-existing, which is missed, or have a de novo development of a post-PK glaucoma, which occurs in these patients.
So
it has its difficulties.
You
I don't
put
say
query like query.
Yes.
CHED1 equal to PPCD, again
it's
another query. But I showed example 2 eyes distinctly that pachymetry is just double. So in this case there is no question of CHED1 or 2. You just take that particular patient, do in one eye PK and another eye DSEC. This is a simple answer.
So thank you very much. Again, we are just running short of time. I'm requesting There is one request from Dr. Muscati, and I have to apologize to Himanshu. We'll just shifting one talk. Again, now I call upon Dr. Somshila to talk about regraft with immunosuppression would be her mode of choice for a thrice failed graft. And sorry for the AV people that we are doing all these changes at the last minute, but it's been a request, a genuine request from our speakers who have to be in multiple places.
So here I want to say that I'm true to my debate in the sense that I don't do ketoprosthesis at all.
Great.
But my other colleagues do it, so I make them do it. And also, I'm a little frustrated that Dr. Basak already spoke against my topic, but Ritika helped me. So I'm going to try and take you through why I think that immunosuppression is a way to go for a patient with twice operated graft in a monocular patient. And having said that, the first biggest overrider would be that this is a wet eye. This is not going to be a dry eye. So this is quickly going through this case of a 36-year-old farmer. He lost the other eye due to trauma in childhood. And he presented with fungal keratitis. We didn't do intrastromal voriconazole, but we straight away did a therapeutic PK. He maintained a clear graft for 6 months, but then he presented again with infection, for which we did the second graft in an emergency situation, and that also failed. And we did a third graft again for an emergency situation because he came again with recurrent fungal infection. And this is the picture on your right side bottom of the slide, showing that the large graft, large failed graft with, it's not very clear, but there are multiple vessels at the graft host junction, and really you know that you're looking at a scenario where if you just do a simple optical graft, it's going to fail. So what do you do for this patient? What we did is that we did an optical graft, not just the graft, but we also injected subcunj Avastin for the vessels. And the patient was started on oral steroids 2 weeks prior and then gradually tapered. And our goal plan is always to use oral steroids, but to also use immunomodulators and take the patient off steroids. And we also use amniotic membrane, which is a frill amniotic membrane, which we put all around the limbus, like a skirt or a frill, and just make a central window. This is about 2 weeks later. Don't have the initial picture, but this really helps in repopulating the limbus. These large grafts would have some stem cell deficiency associated with it. So 4 months down the line, patient is off oral steroids, and he also underwent a simultaneous cataract or sequential cataract surgery, and enjoys visual acuity of 20/40. So this is just one of the patients that I have who have multiple grafts or other reasons for immunosuppression in the graft. This is another case, which is the other side, a case shared by Dr. Sangwan. This is a patient with Moran's ulcer, again one-eyed. And after multiple surgeries, finally, when the time came for visual rehabilitation, he did the Boston ketoprosthesis, but the patient is also on oral immunosuppression. So patient is on Vizolone, on methotrexate. So, and the patient has to be watched lifelong, in fact. So we discussed this a little bit, that low risk do well with topical steroids, but high risk do need, and this is a list of indications of high risk grafts, they do need immunosuppression, we've discussed that. And unlike the previous speaker, I would really disagree. Patient compliance can be very good as long as they understand. And if your practice is driven by such patients, which my practice is, and you're using immunosuppressants every single day in your clinic, then it's really a level of comfort that you have. It's like getting very skilled at doing DMEC, so then that's very easy for you. Similarly, it's just your experience with using these agents. There are multiple literature, but I'll just skip all that, just to say that what should you do? Should you treat the patient yourself, or should you have a rheumatologist or a physician? So you can do either. You can be in the driver's seat and you can train yourself very well. This is some of the baselines which are available in very good literature review, how to use immunosuppressants in patients. And the dose that we use for ocular immunosuppression is extremely safe. I've rarely lost, I don't think I've lost a patient due to immunosuppressant. Nobody's died on me. Of course, death happens, but not due to immunosuppressant. And the systemic toxicity is really not what we think it is. The problem with Boston Capro, and I'm not going into, we all know, every one of us who practice where we see ketoprosthesis is not just Boston Capro. I mean, ketoprosthesis is that it can have complications, yes, but it can have disastrous complications. A patient can have infection, and not just infection, but the patient can come with the ketoprosthesis in their hand, and that's happened, and we've seen that. So I rest my case. So a graft is a beautiful graft, is like Mona Lisa. but a beautiful graft of immunosuppressants is like a strong Mona Lisa. Thank you.
Now, I would now request Dr. Muscati to
Thank you.
speak on
Let's stick to the topic, a thrice failed graft in a monocular patient, keratoprosthesis. I do both types of keratoprosthesis, the Pintucci keratoprosthesis since 97 and the Boston K-Pro. For some reason, Dr. Somashila said we'll only talk about wet eyes. Nowhere in the topic was that listed. So we'll talk about wet eyes, dry eyes, all sorts of patients that you can get with thrice failed graft in a single eye. Now, why K-Pro in a repeat graft failure? The survival rates for first time repeat grafts are 55% at 3.5 years, 28% at 4.5. In second time regrafts at survival rates much less at about 20% at 4.5 years. High risk of regraft failure in some patients. Keratoprosthesis therefore have been designed to provide a clear corneal window where you're not worried about rejections, you're not worried about stem cell deficiencies, because most of these patients have got stem cell deficiencies or very high risk of rejection. So permanent keratoprosthesis is an excellent thing. Dr. Tony Aldave taught us this in 2009 for wet eyes, where you have good eye closure, lids are okay, where there is no keratinization of the cornea. These are the patients, chemical burns, and these are the patients, failed grafts. They do extremely well with this, provided, of course, you look after them well. Obviously, you cannot do a corneal graft and forget it and send him to the village with no supervision. Similarly, you cannot do a keratoprosthesis and forget it and send him to the village with no supervision. We understand that when you are doing in a monocular patient, patient himself is also very worried about his vision and will do a proper compliance and follow-up. So in these patients, the results speak for themselves. Failed graft, 3 times failed graft, we've done a tarsorrhaphy. The uneven thickness on the slit beam, you can't achieve that. The same patient after a Boston K-Pro and see the slit view and the back plate and everything looks so clean and nice. This is a patient I did in Malaysia with 18 previous surgeries, 18 previous surgeries, and he was a milk vendor and went around selling milk and bilaterally blind because somebody threw acid on his face by mistake. They mistook him for somebody else. And I did the Pintucci there in Malaysia in 2006 in 2 stages, after which the patient saw well with 6/12 vision for about 5 years and died while crossing the road in a vehicular accident. Not because of but because the field of vision is tubular. And the Malaysian surgeons then called me up to tell me that I was responsible for the death of the patient. If the patient was blind, he would have never have crossed the road without assistance. So you have these pitfalls. Patients can die on you as well with keratoprosthesis, but it doesn't take away from the safety of the procedure. So this Malaysian milk vendor that I did a Pintucci K-Pro retained 6/12 vision till he died in a vehicular accident. So to conclude, don't torture the patient who has had 3 graft failures with sometimes costly and toxic immunosuppressives. Much better alternative with an excellent Kaplan-Meier curve that you can see. Thank you so much for your attention.
I think looking at both the presentations, we need to take the pluses of each and then obviously choose on a case-to-case basis, particularly so in a monoocular patient. I think with that we would proceed to the next talk. We have, thank you Dr. Somashila and thank you Dr. Muscati. We have Dr. Himanshu who would be speaking on sequential surgeries for management of acute chemical injury.
So first I'm in debate, my opponent has fled and I have walkover. So there is no debate. So you know I'm right. But anyway, I will be gentle to my opponent who does not exist. So the job is, the question is acute chemical injury, sequential surgery versus allocelate, and I'm talking for sequential surgery. I'm a good guy here. So we know that acute chemical injury is a stepwise treatment and there are multiple things we do, but most important thing is reepithelialization. When you achieve reepithelialization, chances of corneal melt is minimum. And that's what is achieved by doing a amniotic membrane transplantation. Amniotic membrane transplantation is fairly simple surgery, can be done even in outpatient basis and in the bedside also. Does not require any immunosuppression, and there is no other technical expertise required with this surgery. Interestingly, amniotic membrane transplant can be done without sutures using fibrin glue. We remove the muck from the surface, put an amniotic membrane over the surface, spread the amniotic membrane nicely, withdraw it half, put fibrin glue there, replace the amniotic membrane there, squeeze it out and make sure it attaches properly, and do the same thing in the superior part, and the surgery is done. The important part is whether this surgery works or not. The interesting thing is that, well, it works. It depends upon what you're looking at. When you do sequential surgery, and when I go ahead with the second surgery, more definite surgery of limbal transplant, you can see I can get a nice plane because of previous amniotic membrane transplant, and that's the power of sequential surgery. When I'm removing the pannus from the surface, you would see the underlying cornea is almost clear, and that's what is achieved by that sequential surgery of amniotic membrane transplantation. With the definitive treatment like stem cell transplant, you can achieve fabulous visual outcome like these kind of cases, and they certainly do well. Interestingly, there are a lot of options available. We can do these things like using Procera, which is done on an OPD basis, or small amniografts. Is this the only surgery? Well, possibly yes also. In some cases, they have been reported that amniotic membrane itself could actually do the visual rehabilitation. There was nothing else required. So from the beginning, we do not need to think that all these cadaveric limbal transplant are the way to go. We know that with the best immunosuppression, the outcome of cadaveric limbal transplant is abysmal. And especially if we do not give immunosuppression, well, you do not have any survival left. What are the other problems? Well, we know that because of the eye banking improvement, we get corneoscleral rims. There is no limbus there. Conjunctiva is already excised. It's stored in MK medium or corneasol, which is meant for endothelium and not for the epithelium. The problem? Well, other problem, you need young donor. You need minimum preservation time. You need emergency procedure. You can't say that I'll do it after 1 week or something like that. And young donor tissue, if you try to dissect out and try to damage the epithelium, endothelium by handling the tissue, it's not ethical. So to me, I would like to conclude amniotic membrane transplant is an important part of acute chemical injury. Sequential surgery have the best outcome. Allo-slit increases the cost and ultimately fails. However, let me play the bad guy also here because Vikas is not here. So is there any role of allo-slit? I would say yes, there is definitely role of allo-slit. We need to reepithelize the cornea. I said earlier that reepithelization is most important. Whenever we do amniotic membrane transplant, amniotic membrane does not last long. It would disintegrate in a couple of weeks' time depending upon the inflammation. Higher the inflammation, faster disintegration. So after a couple of weeks, there is no amniotic membrane, and by then, if the damage was serious, the epithelium from the conjunctiva would not come, and there you again have a stromal epithelial interaction, more chance of melting. So if we have done an allo-slit here, from the slit tissues, the epithelium would grow and hold on for pretty long time. Allo-slit again can be very useful when you are doing a reepithelization and when you are possibly keeping it for a while where you can later on start the patient on immunosuppression if at all you want to start on immunosuppression if you feel it's surviving. And in fact, even if it doesn't survive, it may be able to make the environment such good that reviving or remaining limbal stem cells may start working. So allo-slit does have a role, and whenever you have a serious case, severe case where you have injury to the limbus, I would definitely like to do allo-slit. Thank you very much.
Thank you, Dr. Himanshu. So I saw that I actually wanted to discuss allo-slit with you, though you have also already mentioned in few of the slides. Yeah. So my understanding is that one is in sequential surgeries, you would need to put the child under 2 or 3 general anesthesia procedures, sure. Whereas with a direct allo-slit or auto-slit, you would need only one GA procedure. So would that tilt your decision making towards one procedure?
I don't think GA risk is thing of past. I mean, we are in an era where we can give GA in any cases, and nobody dies under GA. That's the only thing.
Not from the death point of view, but from a child, like a child being put, it's the entire thing, like the family and the entire thing, like any person going through sequential surgeries, like we understanding it as surgeons is different, but then from the patient's like parents' point of view.
Yes, so it can increase the number of general anesthesia, can increase the cost, and we hypothetically assume that we are talking about children, because we do not do any of other cases, ocular surface cases under GA, we don't need to. So even if it's a child, if we are able to understand that not every time a limbal transplant is required in chemical injury, well, that's good enough. Lot of time we are not able to remove the chemical and it may still have persistent inflammation, and hence even your definite surgery, and if at all, if we are talking about autoslet, would not be the best idea. Alloslet gives us a temporary window period and which we can utilize. I think we have to find a bike, you need to scoot there. Yeah.
Thank you very much, Himanshu. We go to the last debate, unilateral central corneal opacity in a 5-year-old. I don't think Dr. Jatin Asher is here. And now I request Dr. Ashmi Deshmukh to talk about the importance of penetrating keratoplasty in such a situation. Can we have the slides on, please?
Good morning, everybody. So the topic is unilateral central corneal opacity in a 5-year-old child. I've been asked to speak for penetrating keratoplasty. So pediatric penetrating keratoplasty has been considered as a high-risk keratoplasty because of the following reasons. One is there's technical difficulty in the surgery. There is a very high rate of graft rejection. There are challenges in the follow-up examinations, and problems regarding amblyopia are also involved. But there are certain criteria for optical iridectomy. One is that corneal areas should be sufficiently clear to warrant an optical iridectomy. So the kind of picture that I have shown here, there's no clear area, so in such cases, penetrating keratoplasty might work better. Again, the site preferred is inferonasal, and superior area is least preferred because it gets hidden by eyelids. So in certain situations, we may not have a choice. Coming to the quality of vision, in optical iridectomy, there is eccentric and blurred vision, but penetrating keratoplasty can provide a central and steady vision. And coming to the field of vision, again, in optical iridectomy, there will be restriction of the field of vision. But in penetrating keratoplasty, a central and complete visual field can be provided. Again, penetrating keratoplasty can remove the opacity altogether. So in a single surgery, you are actually completely removing the cause. But in optical iridectomy, there is always a chance that you might want to do a penetrating keratoplasty at a later stage. Coming to stereopsis, for a proper binocular vision to develop and for the child to have a proper stereopsis, if there is peripheral vision in one eye and central vision in the other eye, then the stereopsis may not develop very well. Then in the presence of a corneal opacity, cosmetic appearance of the child is also different from other children of the same age, and in such a case, the child may be subjected to social pressures. Behavioral abnormalities and personality development of such a child may be affected, and that should always be kept in mind. Then coming to pediatric keratoplasties, these days there are studies which have shown improved success rates like 83%, 76%, and even up to 88%, which is not a very bad rate of success of pediatric keratoplasties. So if preoperatively a complete ocular evaluation is done, and if there are multiple subspecialty services that are involved, including an ASOCT and UBM, and B-scan is done, and if the post-operative management is also done across ophthalmic subspecialties, including glaucoma management and proper amblyopia management, then long-term visual prognosis can be improved. So to conclude, pediatric penetrating keratoplasty is challenging. Successful transplantation with good graft survival can be obtained if a multidisciplinary approach is there. And improved success rates owing to advances in corneal microsurgeries, postoperative management, and a better understanding of risk factors may help in predicting and preventing poor outcomes. Thank you.
Thank you very much, Doctor. But the only assumption throughout your talk was that the graft was going to remain clear, whether we are talking about cosmesis, whether we are talking about...
Yes, sir. Actually, to be very honest, I have always seen optical iridectomies being done, and pediatric penetrating keratoplasties is only through literature that I have actually gone through. So rate of rejections and all, when I have seen patients, rates of rejections have been there.
But that's very nice of you to have told this. But you have to understand, just because the other person is not there to defend himself, there is a role for optical iridectomy in children, and even though this infranasal concept is often taught as the preferred thing, you should use your judgment as to what and where you would do in such an instance. And I will take my chairman's prerogative to make a final comment.
Please.
With no thing meant on you, that if given a choice, and if there is adequate clear cornea available for the eye to go through, I would give the first choice to an optical iridectomy, because the child cannot be able to tell you when the graft is getting rejected and all these attendant complications. But you have put your points very nicely.
Thank
and
you.
I would like to congratulate all the speakers, the chairman, the co-chairman, and my moderator. The most important thing for a chairman is to give the time to the next chairman on time, and I think we have accomplished that as well. And I would like to thank all my speakers for cooperating in this regard, and I would now request Danya to go on with the next session. Thank you very much.